This is a Beggy Sisa podcast.
So we think it's now likely to be more public that 6 doses of cabotegravir are going to be about $175 a year for those 6 doses.
So just for the product alone, and I say approximately because ViiV is based in the UK and the product is manufactured in the UK.
How low that price can go from there is still a great unknown.
Welcome to this edition of our Beggy Sisa podcast. I'm Mia Malan. Last year at this time, there was big talk about an HIV prevention injection becoming available in South Africa. The injection is called CAB-LA and it has to be taken once every 2 months and virtually eliminates someone's chances to get HIV through sex. But there was a problem. We had the science to show that it works, but we lacked the money to buy it. In the United States, where the injection is already being sold, it costs about 54,000 rands for one injection, and you need 6 of those per year if you'd like to fully protect yourself against HIV. So there's been talks about how to lower the price and also how to make cheaper generic versions of this product. To hear more about how those negotiations are going in 2023, I'm talking to Mitchell Warren from the New York-based advocacy organization, AVAC. Thanks very much for joining us, Mitchell, and for your time today. What is your involvement with CAB-LA, just so that our listeners know about it before we start off getting the information from you?
I direct AVAC, which has been working in HIV prevention research and rollout for decades. And over the last several years, we've been very involved in both tracking the clinical trials that showed that cabotegravir was safe and effective. But more recently, we have helped set up what is called the Coalition to Accelerate Access to Long-Acting PrEP. And that is a coalition that is convened by PEPFAR, the Global Fund, UNITAID, WHO, and UNAIDS, and AVAC, the organization I lead, is the secretariat.
Now, about a year ago, there was so much talk around CAB-LA becoming available in Africa, and there was a lot of talk around price negotiations to make it affordable. Where do we stand with that?
The product right now, called cabotegravir, is made by ViiV Healthcare, a pharmaceutical company based in the UK. And they first got approvals in the United States, as do so many drugs. And it is a very high-priced drug in the United States. But they simultaneously began to apply for registration in low and middle income countries at a much faster pace than we saw with oral PrEP. And at the same time, they did announce a commitment to what they call a global public sector price that is available to all countries in sub-Saharan Africa, as well as low and middle income countries throughout the rest of the world. And they announced that they were going to have this so-called not-for-profit price.
So we think it's now likely to be more public that 6 doses of cabotegravir are going to be about $175 a year for those 6 doses.
Now that compares to about $60 for oral PrEP generically that's available in South Africa and around the world. So it is more expensive as a product, but they've also said that as the volumes go up and as they get orders from large buyers like PEPFAR, like the South African government, like Global Fund, that price could drop considerably. And we believe that in the next couple of years, the product from ViiV alone could be closer to $100 or $120 a year for the 6 injections. But again, that's still double the price of oral PrEP. But we're still talking about relatively small volumes. Remember that with oral PrEP, that same tablet that people take for PrEP is made for treatment and widely available all over the world in massive quantities. And I do think that over the years to come, that cabotegravir could begin to drop well below $100.
I want to get to the timeline, but just before we move on to that, for listeners who may not be familiar with terms like oral PrEP or just how effective the injection is, can you give us a breakdown on what is oral PrEP, how does it work, how effective is it, and how does it compare to the long-acting injection?
One of the things that's so exciting is that science has really delivered a number of products that we call pre-exposure prophylaxis. The abbreviated term is PrEP, but it's basically products that you take in advance of potential exposure to HIV. And we now have 3 approved antiretroviral drugs that are used in prevention. For the last 12 years now, we've known that a pill a day, oral PrEP, a tablet combining 2 different antiretrovirals, sometimes called TDF and FTC, we know that it is safe and effective and is fairly widely available in programs. It does require the individual to take a pill every day. Like anything, like a condom, like any health product, it only works if you use it. So if you take this pill a day, you will get very high levels of protection. And then in the last 2 years, we got the evidence that this injectable with a different antiretroviral called cabotegravir was in 2 large clinical trials, including one that took place in South Africa. And the clinical trial was really looking at how effective it was compared to oral PrEP. And remember, oral PrEP you take every day, and it does require adherence to pill taking, whereas the injection you get every 2 months. In the clinical trials, what we found is that the injectable in the trials was actually even more effective for the trial population than oral PrEP. So you'd say, well, how is that possible? If oral PrEP is so effective, we know that some people do struggle with adhering to taking a pill every day. So in the clinical trial, what we saw was that people who got the injection, and particularly the trial amongst women in a number of African countries, including South Africa, showed that there were hardly any infections in those individuals who got the injection. And then we do have a third product with a different antiretroviral called dapivirine. This is a vaginal ring that a woman can insert once a month. And it was also shown to be safe and effective. We also know that it is very dependent on adherence and keeping the ring in. So those studies showed slightly lower effectiveness. But for some women, a vaginal ring may be better than a daily pill or an injection. South Africa is at the forefront and is going to be one of the first countries that's going to have all 3 of those options available to people, hopefully in large numbers.
To get back to the timeline, Mitchell, there is talk about 3 companies that have received licenses to make generic products or versions of cabotegravir, the long-acting injection. Are we going to see branded products becoming available, so these products that you mentioned at reduced prices, before we see the generics being made?
Here's what we know. We know that right now, the only manufacturer of cabotegravir that has been approved for use, including in South Africa, is made by ViiV, what we call the innovator company, the company that developed the drug. You rightly point out that back in March of this year, ViiV did work with the Medicines Patent Pool, and they granted 3 voluntary licenses to 3 different generic companies, all of them based in India, but one, Cipla, does have a facility in South Africa. And over the next 3 to 5 years, they are developing the technology transfer and building up the facility to make this product, cabotegravir, that will eventually reach the market. Now, each of the generics will work with ViiV and with the Medicines Patent Pool to develop the technology, and they'll be on different timelines because different companies have different skills and will need to make different investments. It does take investments because unlike a generic tablet, which generics can make quite easily, this product is an injection. It gets what's called nano-formulated. You have to take the antiretroviral and process it so that it can be injected. And then it gets put in a sterile bottle. So there are many more steps in the manufacturing process. And so the companies have to develop that expertise. And then they have to go to regulatory bodies like SAHPRA in South Africa and be able to show that the product they're making is equivalent to what ViiV makes. And that may be the longest period because every one of these companies is going to have to do a study to show that their product is equivalent, and regulators have to then approve it. We are told from the generics and from the Medicines Patent Pool that over the next 3 to 5 years, those generic companies will begin to make the product, get approvals, and be able to distribute the product. So what happens in that intervening period? So we're sitting here at the end of 2023. The initial vials of cabotegravir coming from the UK manufacturer will begin to reach some countries in small numbers before the end of the year. And those products are being used in both implementation science studies. So these are not big clinical trials, but rather studies looking at how to implement the product. And a number of those studies are in South Africa, and they'll start probably in the new year in 2024. At the same time, PEPFAR, the U.S. President's Emergency Response for AIDS Relief, the very large U.S. government-funded AIDS program, they are also procuring cabotegravir for a number of countries in East and Southern Africa, as well as in Vietnam and Ukraine, to begin programmatic activities in parallel with the implementation science studies. And those will begin in the next several months, late this year and early in 2024. South Africa, we are told by PEPFAR, is on the list to potentially get some of that product in 2024 or 2025, in addition to the multiple implementation science studies that are being conducted. And there are actually a number of those that are going to happen in South Africa. So there will be product from ViiV in South Africa through these different mechanisms over the next several months. And that will be the supplies for 2024 and 2025. And I believe that there'll be even larger supplies beginning in 2026, still coming from ViiV. And I think it's safe to say that by 2027, we begin to see competition from the generics and ViiV. So the three generic companies and ViiV, all four of those companies, really competing for the market to sell to countries like South Africa, to PEPFAR, and to Global Fund. So our job as a global health community over the next 3 years is to actually build a sustainable market for this product. What I mean by that is we need to make sure that there's a demand for this product that is attractive to all of these companies to make the product.
So Mitchell, the one side is there must be a demand, and obviously the larger the quantity that's being ordered, the cheaper the product can be manufactured at. But does ViiV Healthcare have the capacity before these generics become available to make enough of these injections for everyone who would be able to receive it?
I'd say the billion rand question, and you asked it really beautifully. Can ViiV make enough? Can the generics make enough? And the answer is we don't know. And the reason we don't know is we don't know what enough is. And when you look at the oral PrEP market, that again, South Africa, along with Kenya, the first two countries to approve oral PrEP in Africa in 2015. That was 3 years after the FDA had approved the same product in the United States. And the market for oral PrEP remains relatively small. Now, we know from a number of studies and community conversations and dialogues that civil society has done, including AVAC and our partners in South Africa and elsewhere, that there is a stated demand for this product. People are excited by it. It's safe, it's effective, people are familiar with injections, but we don't know if that kind of novelty interest will translate into programmatic demand. So the first issue is we don't really know what demand is. I believe that if we see the injectable PrEP market grow in the next 3 years, similar to what has happened with oral PrEP, we will be pushing probably the boundaries of what ViiV can produce. But I believe that ViiV can produce more if there's a demand. And I believe that the generics can go faster if they know there's a demand. And here's one of the interesting things about how this works. The generics are sitting there and they're looking. They have to spend millions of dollars to build capacity and to do these studies to show equivalence. If they see PEPFAR or the South African government or the Brazilian government demanding large numbers of vials, and if ViiV can't supply them, that's going to be a great incentive for a generic to say, oh my, we better spend faster to get our product to market even faster because there's a demand. If we don't see demand, then a generic's going to say, well, maybe I shouldn't spend $10 million to build this facility. Maybe I'll just wait. So this is why when I talk about building a sustainable market, we need to work with the quantities that we have. And there is absolutely a chance that over the next 2 years, there is more demand for this product than ViiV can supply. And that would be unfortunate, but it would be the best incentive for ViiV to buy larger quantities of manufacturing so that they can make more, and it would bring in the generics to accelerate their processes. So I think the answer is we don't yet fully know if ViiV can meet that demand. They are working closely with PEPFAR and Global Fund because they are the big purchasers, because they're going to be buying on behalf of many, many countries. And we, through this coalition to accelerate access to long-acting PrEP, are really pushing PEPFAR and Global Fund to name the quantities that they could absorb in their programs, even if ViiV can't supply it in 2024, so that at least we know what the target is for that demand. And one of the challenges in this is that, people say, even back with oral PrEP, and Mia, from many years of our collaborations, that I almost always bring up the female condom. People said they wanted the female condom, and the company made a lot of female condoms that never got used. And that's always this tricky balance. Now, we believe that people really do want cabotegravir, but how we deliver it, how we help healthy individuals come in every 2 months to get an injection, that's a pretty significant ask of the individual, and more importantly, of the health system. So that's what these implementation science studies are going to be doing, in part, to really help us understand how to deliver this product and who wants this product.
So clearly, from what you're saying, is that we need these implementation trials to figure out whether people really would like the injection. Otherwise, we run a huge risk of ViiV upscaling its capacity and then no one wants it. So we need this period to figure out what that uptake might look like. If we look at generic production, you mentioned that if there's an incentive, they may accelerate. What timeline are we looking at? What would be fast and what would be slow for a product to become available?
One of the things that is particularly important is to understand what needs to happen to get those generics to market and to figure out which pieces of the process we can speed up. So they first have to get the technology transfer, and that's the collaboration with the medicines patent pool and ViiV, and that can be accelerated. So that's already happening. They need to then build or adapt their facilities to be able to make this particular product, and that can take some period of time, differently for each company depending on what their baseline is. But again, they may spend more, or perhaps even a donor might incentivize them and give them money to build out some of that. So that's an area that you can compress. The one thing that is most challenging in terms of the timeline, frankly, is what's called bioequivalence. The generic companies need to show the regulatory agencies that their product is equivalent to the product that regulators already approved from ViiV. Now, with oral tablets, you basically can do a relatively rapid study to show that, generic X is the same as brand Y over a short period of time by a small study with people taking the tablets, and it shows that their body has the same drug levels. Remember, this injection is every 2 months. So the regulators will likely require some longer period of months to see if the human body with the generic product metabolizes and absorbs the product in the same way as the ViiV product. So these bioequivalence studies are the part of the process that's probably going to take the longest and is the one that probably can't be shortened, because regulators have said this is what we need to approve your product. And that's just a regulatory requirement. But when you put all of the pieces together, companies have said it will take between 3 and 7 years. And the question is, how can we get closer to 3 as opposed to waiting 7? And that means they're going to have to spend money of their own, or they're going to have to get investments from donors or others to go faster. I think it's safe to say that we might get closer to 3 or 4 years, and the licenses were granted again in March of 2023. So I would hope that by 2027, we may see generics on the market, maybe even by 2026.
Just for clarity, Mitchell, when you say the trials for bioequivalency can't be shortened, how long would such a trial be for this particular injection?
I don't know that there is a set frame yet, but I believe that study could take several months or maybe even a year to see how the product works.
And also for clarity, will the bioequivalency trials or studies just test whether the drug levels are the same in someone's body, or would it also need to test whether, HIV infections decreased because of the use of this product? Because that may take much longer, right?
That would take much, much longer, and we would never get a generic. Because doing a trial like that, we now know that cabotegravir is safe and effective. So you couldn't do an efficacy trial. And regulators have said very clearly, you don't need to. There is a well-trodden path of this idea of bioequivalence that every generic has to have. So basically, once the innovative company does clinical trials and gets their product approved, and all that data showed very clearly the product works, but they also gave us a huge amount of data to know how much drug needed to be in the body to provide protection. And that's what regulators do for bioequivalence. They look for those markers to know that it is equivalent in the body. And that's how every generic is approved, by being shown to be equal in its dynamics within the body, not needing an efficacy trial to be repeated.
Now, if we look at countries who already use cabotegravir, the long-acting injection, for instance, the United States, are there any lessons that we've learned about take-up, about how much people like the product? I remember a year ago when I spoke to researchers, one of the things that they raised was, we don't yet know, it's quite a deep injection that has to go into your muscles, whether that would become an issue, whether people would say, but it's too sore.
The uptake has been fairly slow. It's not that it's not of interest to people, but one thing, and again, we know this from not only HIV, but we certainly saw this with COVID, that with any new product, one of our biggest challenges is the health systems that deliver it. And we saw this with COVID vaccines, where you had a great functioning health system, you got large quantities of vaccines, people got access to it. In countries that had less robust health systems, you saw a struggle. And guess what? The United States, for all of the wonders of driving science, has one of the most debilitating health systems in the world. So rollout of new products can actually be quite slow. And we're seeing that with cabotegravir in the United States. And it's not for lack of interest by individuals or even by providers in HIV programs. It's the health insurance system. The product is very expensive. Health insurance companies have required enormous amounts of paperwork that have made it very complicated for people in the United States to get the product. So in fact, the numbers are lower than I think many people would have imagined. And what's interesting is at a conference in the United States of infectious disease doctors that meet every year, there were data presented that showed from the United States, a relatively small study, but it showed that just over half of the people who even got a prescription for injectable cabotegravir for PrEP got at least one injection. So even though people got the prescription, only about half got their first injection. So the numbers are not skyrocketing. And again, I think the interpretation there is it has more to do with the difficulties of navigating the US health insurance system than it does about actual desire for the product. So uptake has been fairly slow. And I will say this is one of those issues, Mia, that I don't know what will happen over the next 3 years. My crystal ball is not particularly strong. But I actually think that given the support from PEPFAR particularly, who've really been quite progressive in wanting to advance PrEP programs and including injectable PrEP, I believe that we could see more people accessing injectable cabotegravir in low and middle income countries and in other high burden HIV countries, and particularly in South Africa, in the next 3 years than are getting cabotegravir even in the United States. And that would be a remarkable transition because, as you know, most times we wait decades for an innovative product to go from high-income countries to places in East and Southern Africa or Latin America or Asia. But I believe cabotegravir may be one of our first examples, if we do the right things as a community together, that more people in high-burden HIV countries in Africa will have access to cabotegravir than even in the United States.
Now, I would like to talk about what are those right things that we need to do, Because as you've mentioned, one of the lessons clearly from the United States is if you make it difficult to get the product, then people are not going to use it. So how are we going to make it easily available? Big difference perhaps is that it will be available for free in countries, most likely, who get donations or get donors to pay for it. But that still doesn't mean they will use it, right? What do we need to do to make it available easily?
Well, we did a body of work over the last 6 years to look at what are all the lessons of oral PrEP. First and foremost, we have to remember that this is not just a product. This is not just an injection. Obviously, cabotegravir itself is an injection every 2 months, but a good PrEP program has to be a program not focused only on the product. So lesson number one, we need to reframe risk in the context of PrEP. If we start saying we need to find people at risk of HIV and offer them cabotegravir, I believe we will fail. We need to reach people where they are and in the conversations they want to have about their sexuality, about their relationships, and then we need to offer them choices. Condoms, oral PrEP, if you're a woman, the Piperine vaginal ring, and cabotegravir. And we need to do it in a way that is not stigmatizing and doesn't make it seem like we're focused on their risk, but rather we want to focus on what they want to get out of their sexual life. So that's part one. Part two, we need to generate demand for PrEP. And this is tricky because there are a lot of people who will say, well, our supplies are limited. So if we create demand, we're not going to be able to meet it and people are going to be frustrated. And that's true. So we have to do this really strategically with the supplies that we have. Just recently in South Africa, now pharmacies can deliver oral PrEP and treatment. This is a huge step forward to really simplify things. Now, cabotegravir is clinic-based, certainly at the outset, but how might we begin to make at least the wraparound services simple for people and desirable for people? We also know that new products can create new stigma. When the female condom was first introduced, people said, oh, it was marketed to sex workers. And people said, oh, that's a sex worker product. I'm not a sex worker, or I don't want to be identified as a sex worker, so I won't use that product. The same thing happened with oral PrEP. In a number of places, it was first introduced as a product for gay men and other men who have sex with men, or for sex workers. And in countries where you carry a lot of stigma around being gay or being a sex worker, that creates a stigma for the product.
So Mitchell, if we need to ensure that we don't stigmatize the product or PrEP, does that mean for the long-acting injection, when we do implementation trials and when we phase it in, we shouldn't phase it in among key populations, but the general population?
Unfortunately, people have made it quite binary historically. They say, well, either we make it available to everybody, which is not financially feasible sometimes, or we make it available only to key populations and we create that stigma. I don't think it's as binary as that. We need to make people aware of these PrEP options as a generic, general population issue. And you can still prioritize within programs without stigmatizing. So it can be done. And companies that market products do this all the time. We are all quite different individually. And companies who spend a lot of time thinking about what we call market segmentation, they know this. Everybody may know that a product exists, whether that's Coca-Cola or an Apple iPhone, but then they do strategic marketing to reach specific segments of the population with slightly different messages. So part of this is making sure we don't just say cabotegravir is for sex workers or for high-risk people or for gay men and other men who have sex with men. We need to say injectable PrEP is an option for people who want to really take control of their sex lives and live long, healthy, enjoyable lives. And then we need to simultaneously have very targeted programming that allows us to reach populations.
Mitchell Warren, Executive Director of AVAC, which is based in New York. Thanks so much for your time and your patience today with making a very complex issue easier to understand. That's it for this podcast edition. I'm Mia Malan.
This was a Peggy Caesar podcast.